Right, so hi, good evening, everybody. I think there's about 30 online at the moment for this webinar. Are there more coming in, Victor, or shall I just start?
Yeah, people are getting here.
Okay, I'll
10, 15, 20 people are getting here. We can wait maybe a few seconds.
Okay. We'll wait for the online queue.
All right, maybe we can start.
Super, thank you. Good evening and welcome to the webinar with Jonathan Pink and Mark Morton. Thank you very much for spending your Monday evening with us. You can see there's 4 faces along the top. I'm Karen Simpson-Jones. I'm the owner and manager of VetLig in the United Kingdom. Along next to me is Victor Robelo, who is the CEO of Novetech in France and basically the rest of the world. And we work together. And alongside next to him is Jonathan Pink from Willows. And then further along is Mark Morton from Chester Gates. So we've decided to run this webinar tonight because there's more vets using our products and asking me more questions that I can't always answer because I'm not a vet, but I know vets who can help answer these questions. So that's why we're putting this webinar on tonight. So what we're going to do, it's going to be very informal. Mark's going to start and then followed by Jonathan and then finish it with some questions. I guess we shall start with Mark.
Great. Hang on, let me just share my screen. Evening, everybody. Correct. Can everybody see that now? Is that good? Yeah.
Yes.
Great. Okay. Okay. Thanks everybody for joining. Welcome to the webinar. We're mainly going to sort of focus on post-operative care tonight, but there's a sort of bit of an introduction and a bit of structure. I thought we'd just look at the reasons why we do some of the things post-operatively that we do, and to give a bit of background to that. So I'd like to welcome Jonathan as well tonight, who's a really experienced surgeon and does a lot of these cases as well. So you've got sort of 2 people here who can share our experience. I'm sure there's other things that people are doing as well. Plan will be, as I say, we'll just discuss a bit of background. We'll talk about what we do from a post-operative care point of view. We'll look at some of the other complications that you might see, and then the end of the session tonight will be sort of an open forum, if you will. If you've got any questions, maybe we can give some answers, maybe we can tell you our thoughts, and equally, if you've got any tips and tricks to share with us, that would be great. One thing we're not going to do tonight is we're not going to talk in detail about how you use VetLig products and surgical techniques, etc. If you want to join a course on those, there's one again in London in February. They're regularly held in France, I know as well. We have done a few online things, and maybe we can look at that later in, or probably early next year now, if the demand is there. I'm sure you'll all be familiar with the range of products. If you're not, have a look on the Novatech and the VetLig website. There's loads of information sheets there about the surgery and the products. There's some great instrumentation that goes along with that. Makes it easy. You can all sort of in one box, everything that you need there now for every size of ligament and screw. Novatech and VetLig are about to release some new guidelines. This has been really useful, actually. It's just a really good summary of all the screw sizes that are available, and sort of what drill tunnels you should use for each one, and then the different indications. And I know Karen's will share this with everybody who's registered in the next few days, and certainly they'll be on the website as well. So keep your eye out for those, and I've certainly found this useful from a surgical point of view, just having this as a ready reckoner to make sure I'm doing the right thing. So just very briefly, we're just going to look at a little bit about the background of tendons and tendon injuries and why we manage these cases the way we do, because it is a little bit different to repairing fractures and things. Tendons are dense bands of collagen-rich fibers. They generally connect muscle to bone. They're mostly type 1 collagen, and the fibers are orientated parallel to the mechanical axis that the tendon works in. It's a hierarchical structure. There are some tendons that have synovial sheaths around them, particularly in areas of high mechanical stress. And the other thing that we see in some tendons is at the myotendinous junction, there's a really complex insertion of collagen fibers that reduces the tensile strength on the tendon itself as muscles contract. But that is still the weakest part of the muscle tendon unit, and that's been shown in numerous studies and certainly in the testing that we've done. Tendons are adapted to loading. That is their job. They have a low oxygen consumption. It's about 7.5 times less than skeletal muscle. They have a low metabolic rate and don't consume much energy, and they have a really sort of low vascularization compared to other tissues because it's simply not required. However, whilst that's really good for how tendons function, it's terrible for healing, and that's why getting tendons to heal can be an issue and why we see some of the problems that we see. When tendons heal, it's not uncommon to get adhesions secondary to scar tissue formation, and that's a problem because it can affect the gliding function of tendons. The other problem with tendons when they're healing is that they're generally under some tension. Now, if you can relieve some of that tension, and we'll talk about this, great. But tension causes a problem called gap formation. Now, this is more of an issue, I would say, with primary repairs than some of the chronic gastroc things we're going to talk about tonight. But that tension, if it causes gap formation, causes a problem. We'll skip over that one. The major thing to sort of say with tendon injuries is there is no quick fix here. So I'm certainly not going to be able to tell you something tonight that's going to help you cut corners. And I'd be incredibly surprised if Jonathan does as well. And if he has got something that can help me cut corners, I'd like to hear about it. Most of these repairs are going to require immobilization. It's really important when you start treating these cases that owners are aware of that, and that they're aware there's a significant rehab period after the sort of initial post-operative period. There's a real risk of repair failure, whatever you do. And again, there's things we can do to mitigate that, but you need to make owners aware of that. Some of these chronic gastroc degeneration cases where you get that scar tissue forming at the insertion, it's not uncommon to see that as bilateral disease. So again, you need to warn the owners of the risk of that. And, you know, arthrodesis is always an option. It's not what I recommend for these cases, but it's on here really because, yes, you can use it as a primary treatment option. To be honest, I think we can do better than that and we can get these dogs functioning again, but it's always a fallback. So if you do have an issue, arthrodesis is a salvage procedure that you can do at any point. So there's always a sort of get out of jail card there in the background. Again, we'll just skip over this very quickly. This is, again, is not a webinar on the surgical technique, but this sort of gives a bit of an idea about why we need to immobilize tendons following repair. What we know about tendon healing, well, there's lots of work around that shows the benefits of primary apposition, and that primary repair is better than conservative or delayed management. A really key thing when you're repairing tendons is to avoid gap formation. Gelberman showed a sort of classic paper that that tendons that heal with more than a 3 millimeter gap are significantly weaker at 6 weeks. And Nielsen and Pluhar showed that tendons have much greater strength if repair is performed within the first 3 weeks of injury. Initially, when tendons are damaged, when they're repaired, they initially lose all their holding power. So for the first 4 or 5 days, tendons after repair aren't doing very much themselves. You're totally relying on the sutures you've put in. That's true for a primary repair. And it'll be true for when you've put the a Vetleg implant in, that it'll be the sutures that are holding everything to start with. To start off with, you in the first couple of weeks you get some collagenization and fibroplasia, but the sutures must resist gap formation in a primary repair for 3 weeks at least, and that's going to be the same with initial repair. With a Vetleg implant, the strength of your sutures, that's what you're relying on until you get integration of the implant. When you've got a primary tendon repair, you are relying on new collagen forming to help it heal. Now, collagen needs to be exposed to load, so all the fibers develop in the correct orientation. And one of the questions that I have, and I don't know the answer to this, is how much load should we allow these, or should we put through these tendons when they're healing? And again, whether it's a primary repair or a chronic repair, we're trying to get new collagen to form, and possibly what we should be doing is increasing the load that goes through them. Julian did this study where they looked at the tensile strength after tendons following repair, and at 6 weeks tendons only have 56% of their normal strength, and by a year that's only gone up to 79%. So whilst the tendons are not up to full strength by a year, normal function only requires about 25 to 30%. So at 6 weeks, some exercise is certainly feasible, but we need to be careful. How much exercise? Well, again, I don't think we know the answer to that. So why do we need to immobilize these? Well, we've talked about the problems with delayed healing, but there's a few other things here just to talk about around immobilization. So Andy Moore's had a couple of great papers back in the early 2000s where they looked at primary repairs of Achilles tendon injuries, common calcaneal tendon injuries, and also where they looked at when you've got these chronic cases, suturing the tendon back down to bone. Nice papers if you haven't read them before, but in one of them there's a really nice calculation where they try to sort of estimate how much load a dog puts through a normal it's common calcaneal tendon during normal function, and it was near enough 400 newtons for a 30 kilogram dog. But that didn't take into account cyclic loading. So that was just sort of from a load to failure point of view, or a sort of one-off load point of view. With regard to immobilization, we know that there are significant complications associated with external coaptation. Richard Meeson from the RVC did a study that's really commonly cited where they showed that 63%, I think it was, of cases that had a cast placed ended up with some sort of soft tissue injury. Now, the vast majority of those were mild, but 20% were severe. It didn't really matter how long it was on for. The injuries occurred all through the period of mobilization. And the more severe the injury, unsurprisingly, the longer it took to heal. Greyhounds, lurchers, etc. are more prone to problems, but there were significant costs associated with sort of treating these injuries on top of the costs already incurred with the original treatment. So external coaptation can be a problem if it's not performed correctly. It can make matters worse than they were to start with in some cases, and I'm sure we've all seen patients that have suffered with injuries. The other thing to add is that there's this study from Lister, and they looked at the load in tendons with sort of micro stress gauges whilst they were immobilized, and they showed that immobilization actually may not fully reduce the load that goes through tendons. And this was a model looking at common calcaneal tendon injuries or Achilles tendon injuries. What I would say about that study is they immobilized these limbs in a normal standing position. So I think if you immobilize them in extension, you're certainly unloading the tendons significantly, and I imagine that those findings wouldn't be true in an extended limb. But again, having said that, we talked earlier on that you might want some load going through tendons, so possibly being in a normal standing position, either initially or during the sort of healing process, might put a little bit of a load through it, which would be good for reorientating fibers and helping with integration, etc., etc. So back onto the sort of treatment with vet leg implants. So how strong are these repairs, and how do they fail? Well, there's 2 published studies on the biomechanics of these repairs. One we did back in 2015, and Philippe Boutin and then the team repeated one a couple of years ago now. In our original study, well, in both studies actually, the weakest part of the repair is proximal, so where you've sutured it into the myotendinous junction and into the tendon body itself. And in both those studies, as I say, that was the weakest part. In our study, the mean load to failure approximately was about 260 newtons, something like that. In the other study, they actually used a slightly different suturing technique. And the implant between these two is manufactured by a different company as well, though the technique is essentially the same. And proximally, they had failures about 690 newtons, so significantly higher than we had in our original study, but still distally, the sort of when they tested, or when we tested failures distally, you were up about 1,000 newtons for the implant pulling out from around the screw. So there's a lot of load going. They can take a lot of load, but and our study didn't exceed that calculation by Andy Moore's. The second study, the load to failure proximally is higher, but that's based on a sort of one-off load to failure. Again, doesn't take into account the sort of cyclic loading you would see in a dog if it was walking around on this repair immediately after surgery. Just to show you the other slight difference between the 2 techniques. So initially we had a technique with a tunnel drilled sort of straight down the calcaneus. There, there's a sort of blind ending tunnel. And now the sort of technique that they developed in France uses 2 tunnels. So a tunnel going from the tuber calca or the tuber calcanei down through the back of the calcaneus, and then the implant and the screw is placed in a perpendicular tunnel going across the calcaneus, as you can see in that view there. So that's the other difference between those 2 studies. So what do I do? Well, my experience with these is when you've done your repair, immediately after surgery, I recognise that you get some post-operative swelling for the first 3 to 4 days. You get a lot of neovascularization with these chronic gastroc issues. Anybody who's on this this webinar that's operated on knows that they tend to bleed and ooze from every little bit of tissue. All that scar tissue it's not a bloodless surgery, shall we say. And I think that probably contributes to some of the swelling. So I will immobilize these in the immediate post-operative period with a padded splinted dressing in extension with a cranial splint. After 3 or 4 days, I will see these patients back and I will swap that dressing over to a cast as long as the initial post-operative swelling has gone down and there's no issues with the wound, which generally there isn't after 3 or 4 days. They look fine. And I will keep that cast on for 6 weeks. I can hear the intake of breath from all the people on this webinar about me proposing to do such a thing. I think cast placement is fraught with difficulties, but I think it's all about how you put the cast on. Hopefully we can share a few tips and tricks in a second. I'll instruct owners to check that cast themselves twice a day, proximally and distally. usual guidelines I'm sure that you all use, that it shouldn't change shape, it shouldn't slip, you shouldn't get it wet, it shouldn't smell. Any hint of a wound proximally or distally, it needs to be checked, ideally by us, and I get their own vets to check it on a weekly basis. The first 6 weeks is very, very strict rest, just short lead walks for toileting, with some sort of bag or protective boot on to keep the cast nice and clean and dry. And then we'll see it back after 6 weeks for cast removal. If you've done a sort of primary repair where you've sutured it and you've put a calcaneal tibial screw in, I would take that out at that stage as well. And then after that, it's another 6 weeks of strict rest, but without the cast. And I don't want the dog to really be doing any more exercise at that point than it was doing with the cast on. But now, of course, the dog's loading it. So I want them to just sort of still take it easy. And then we'll see it back again at the end of 12 weeks. And then it's another 6 weeks of progressive lead walks from there. And that's what I would recommend for all these cases that I see. I am possibly overly cautious with that, but we don't tend to see too many problems with build-up. So from a splinting point of view, in that immediate post-op period, I use this product here, Dynacast Prelude. It's a sort of padded fiberglass splint that they're using people for making back slab casts. Not an advert for them at all, but it is nice to use. You can cut it to length, you can seal it back up again. And it's just essentially a big massive roll inside that box. You cut the length you want, and I'll show you how you put the bandage on in a second. But you sort of put most of your bandage on, cut it to length, run it under the tap, get all the excess water out of it, and then the fiberglass goes off and conforms to the leg. It's padded, so it's less likely to rub, and then you put a couple of final layers of bandage on top of that. Equally, you can do a very similar thing using normal casting material. So I would just lay 4 or 5 strips the right length on top of each other, and cut it, and as it starts to go off, place that on top of the bandage and form it to the shape of the bandage. So again, it sort of molds to the dog's leg. A little tip there is, before you do that, you can cover the bandage in cling film, so the casting material doesn't stick to it. You then take the cling film off before you put the splint back on. And then if you're regularly changing the dressing, you don't have to make a new splint every time. That's the good thing about the Dynacast. It's got that sort of padded layer on the outside, so it easily sort of pops on and off the bandage. There's other options there as well. So using thermoplastics, either to form a splint or as part of an orthotic. I have heard of people having orthotics made for these dogs before surgery to use post-operatively. The one thing I would say about that is that you can get some swelling afterwards, you can get a bit of thickening of the leg after surgery, and I would have a slight concern about having a very expensive orthotic made pre-surgery in case it didn't quite fit afterwards. The other downside to an orthotic is it sort of gives the owners a license to take it on and off, which for me brings in concerns about the leg not being immobilized fully during that first 6 weeks. So I'm a bit hesitant of anything that an owner could take off themselves. So here's my sort of little bit on casting, and this is how I do it. I recognize that there are lots of different ways to do this, but the key thing I would say about casting is it is all about the technique. And there are lots of different techniques, and if you're good at your technique, you will see very few problems. When you if you don't think about what you're doing and you just sort of stick casts on, that's for me when you start to see big issues. So this is how I would start. So you can see there, this is 3 or 4 days after surgery, surgical incision, you can see there, all looks fine. I would put a little bit of sort of padding between the toes, but not too much. And then I would apply a stirrup on either side of the leg. Okay. I was taught this technique by Richard Whitelock when I was his resident back at Davies Vet Specialists, and it served me well. I always sort of wondered why he was so sort of fastidious when he was putting these on, and I learned quite quickly that you really have to be. The other thing that I use is this stockinette. So it's tuber grip. Basically, if you're buying it, you generally need to buy it as a human product, and some of them have different sizes. That are the one we commonly use is Latin, and I can never remember whether this is an A or a G. I think it is, but it's this basically the smallest size you can get for a child or an adult. And I would measure them just with the sort of roll of tuber grip, how far I want to go up the dog's leg. And that's right from its toes all the way to just underneath its tibial tuberosity. And I would cut a double length of that and fold it back on itself. So there's sort of 2 bits there. Okay. This is the slightly awkward bit. So you've got your stirrups on your stockinette. You need to slide your own hand up the stockinette, grab hold of its leg, and then pull the stockinette all the way up the dog's leg. And it looks something like that. You can see the stirrups are still sticking out the bottom, or you can just about see them, and they're stuck to themselves. I would then apply sort of 1.5 layers of a sort of soft band or padded type dressing material. I'd cover that with a sort of single layer of conforming bandage, leaving a bit of the stockinette sticking out at the top. Okay. All the time when you're doing this, you just need to keep looking where the tibial tuberosity is and where the patellar ligament is, because you want to make sure that your cast ends up well below that. It's really easy to get carried away and it go too high, and then before you know, you've got a cast that's sort of going to start irritating the patellar ligament of the stifle. If that ever happens, interestingly, of course, VetLig sell a product that you can use to treat those injuries as well. Cast material wise, I just use a fiberglass cast material. There's loads of different ones available. We use vet cast, and then we would apply that up and down the leg, sort of 2 layers all the way to the top, and then we would sort of trim that. You can just see the nails of the toes peeping out at the bottom, and then you can just see that as the cast material is going off, I would just fold the excess bit of the stockinette over the top of that cast. The other thing I do just before I do that is at the back of the stifle, I would cut a little sort of tiny V out of there, just to give a little bit more flexibility when the dog flexes its knee, so it's less likely to cause a rub. I would then get my 2 stirrups from the bottom and separate them and fold them back up on the side of the cast, and that's the same on the other side. And then sort of top and tail the bandage with a bit more vet wrap, stick that bit of stockinette down at the top, and then cover it with vet wrap, which is, you know, really easy to change if it gets soiled or damp or whatever. Obviously, the cast gets significantly soiled or damp or dirty, then you do need to take it off and change it. Okay. So if you have got a cast on a dog, I sort of told you about the instructions that I give to an owner. As any hint of a problem, get it off. Check what's going on underneath. It's not a problem to put a slightly shorter cast on or a slightly longer cast, or manage a wound with a soft padded dressing with a splint on like we did earlier on, if you've got a problem. And if you treat them early, they rarely develop into something that's an issue. It's when they're neglected that you start to see severe problems. Just one other thing to show you that I sort of missed. It would be this layer here. So if I was putting a splint on post-operatively, I wouldn't use the stockinette underneath. I would get to this layer here with the sort of conforming bandage on. And then it's at this point that I would put my cranial splint on down, well, cranially, and then I would bandage it in with another layer after that. And you can see I've really got this leg with the hock as extended as possible. Okay, so I'm delighted to welcome Jonathan to tell you about how he does his casts. And yeah, there's more than one way to do this, and I'm interested to hear what Jonathan does. So If I stop sharing and
Then I will start. Great. Has my screen come up? Can you see it?
yeah, all good.
Excellent. Good. Well, good evening, everyone. Yeah, thanks, Mark. It's a lot of what we're doing is very similar, with, I guess, divergence when it comes to the support that we apply post-operatively. So I've tended to go for a bivalve cast, which I can take off and replace multiple times during that 6-week period. As Mark says, you get a lot of neovascularization, the tissues here, there tends to be a lot of seepage. And so in terms of wound closure, I tend to go with intradermal sutures, and then I use tissue glue. And my rationale is to try and minimize seepage from the wound in those initial sort of 48 hours, 96 hours after surgery. And part of that is trying to minimize the risk of any bacteria tracking into the wound and maybe increasing the risk of infection. I make my bivalve cast immediately following surgery. So I don't make, I don't apply a temporary support and then go back a couple of days later. And I certainly see the rationale for doing that. I guess maybe I get away with it because my cast is limiting some of the postoperative swelling that I might see otherwise. And as yet, I haven't had any issues with that. So I'm a great fan of stirrups when it comes to things like modified Robert Jones bandages. I don't tend to use stirrups here. So I'll apply a layer of soft band, generally the 7 centimeter soft band for a Labrador sized dog. And I aim for about 2 layers, maybe 2.5 layers, with roughly a 50% overlap. Having applied that, I apply the conforming bandage so that it is snug but not tight. And then temporarily apply a layer of vet wrap over the top of that. And it just helps to, I guess there's a couple of reasons. The first is it's a nicer surface for the cast to adhere to. And the second thing is it stops some of the moisture tracking into the bandage material. And it also, maybe thirdly, gives you a nicer conformation, nicer shape to the bandage material for the cast to conform to. As Mark does, at this stage, I come right up towards the tuberosities. So not any higher, but coming up to the top of the tibial crest. And I'll leave the digits, central digits sticking out, or at least the nails sticking out distally. The fiberglass cast version that we have is Delta cast, but it's the same as the vet cast. You are meant to soak it in tepid water. So I think they normally say 20, 21 degrees, which for me is water which feels cool but not cold. So I'll soak it, squeeze it out, and then I'll wrap around, starting distally. I tend to do typically 3 or 4 turns just at the very distal aspect of the bandage, and then I progressively work my way up and then back down again. So the sizes we have are 2-inch or 4-inch, so 5 or 10 centimeters, and I tend to go for the larger size, so the 4-inch, the 10 centimeter version. And that will normally allow me to get maybe three layers on a medium-sized dog. So this is where my system becomes much more convoluted than Mark's. So at this stage, I want to turn it into a bivalve cast, which I can easily take off and reapply, and which won't cause pressure in the areas that I perceive as being problematic. So having waited the 4 or 5 minutes for the cast material to set, I then borrow a Sharpie from one of the nurses, and I draw on some lines. So the main split in the cast will run caudally and cranially. So I draw a straight line down the center line of the caudal aspect of the limb from the top of the cast down to the bottom of the cast. I then do the same thing on the cranial aspect, but on the cranial aspect, which is the bottom right photograph, you can see that I put this zigzag in. Now, there's a kind of modification that we added in a few years back, and you can argue it doesn't really achieve a great deal, other than it means that when you put the cast back on, you don't run the risk of one segment moving proximally and the other distally. It keeps a very nice proximal-distal alignment between the two halves. I draw an arrow on with proximal just to make sure that if somebody else replaces this at some stage, there's no confusion as to which way it goes on. And whilst you might think that this should be fairly foolproof, I have seen these put on the wrong way up. So I put a little arrow with a proximal to indicate which way it's going to go. And then I draw on 2 cutouts. I draw on a kind of circle or an oval shape over the calcaneus, because I really want to minimize any pressure there. And then I create a U shape over the caudal aspect of the proximal cast, so that when the dog flexes at its stifle, there won't be pressure on the top of the cast. So having made my drawings, I then get the cast saw and I split down the caudal aspects. I don't pay any attention to the cutouts at this stage, but I cut the caudal aspect of the cast down the midline, and then I do the same cranially, but putting in the zigzag. And it's surprisingly easy to cut relatively curved or short or complicated shapes with the cast saw. So it's not a challenge putting in this zigzag. So having made the cut completely on the cranial and the caudal aspects, I then put it apart. Typically the vet wrap will have adhered to the cast, but it peels off quite nicely. And then that leaves me with my 2 halves of the cast. So the cast cut into 2 bivalves. So I then reassemble it. So I put the 2 halves back together, and I put a run of tape around circumferentially up at the top and down at the bottom. And then I use the cast saw to cut out the cutouts. So I'll cut out that oval shape, which will fit over the point of the calcaneus, and then U shape at the top. And I've generally made the cast longer in a proximal direction than it needs to be. So I'll take off typically 1 centimeter at the top on the cranial aspect, and that way you get a nicer finish to the top of the cast, and there's no risk of it rubbing up towards where the patellar tendon is. I will normally replace the soft band. I think the key here is to remember how many turns of rat wraps, or how many turns of conforming bandage and soft band you've used. So I ensure that I use the same size, the same overlap, and the same length of material. And then I should find that the 1 half of the cast will go on very nicely, and it will be a snug but not tight fit. And then I put the second half on, and then I cover the whole lot with vet wrap. So what I haven't shown in this photograph is I will then tend to cut out part of the vet wrap right at the top caudally, because again, that vet wrap will, I find, tend to dig into the skin when the dog flexes its stifles. So I just like to relieve the pressure up there. I don't trim any of the cast distally, so I want to leave it so that the central nails stick out the bottom, so that owners can monitor for swelling. I did try cutting away some of the cast on the dorsal aspect, but I found there's a tendency there to have soft tissue morbidity, which I don't see if I leave the cast full length. So I'll make my cutout over the calcaneus, cut out caudally on the proximal aspect, but distally I leave a complete cast. This is a dog's got bilateral disease, hence some a slightly odd gait, but that's what I would expect the day following surgery. I tend to send these dogs home the following day, and my postoperative care is very similar to Mark. So I'll recommend 5-minute lead walks 3 or 4 times a day for toilet purposes, but that is it for 6 weeks. I get owners to ensure that the cast stays dry. So I tend to have a cast which fits very nicely inside a 1 litre fluid bag. So I'll often get our nurses to save some of those, and then I give a batch of them to the owners to slide over the cast. They tend to be much more robust, I find, than a polythene bag. So I get them to use that if it's damp at all outside. So I was really reinforce the idea that the bandage needs to stay dry, that they mustn't allow the dog to overdo it, to be too active, and to monitor for any indication of any wounds, proximally or distally, or any signs of discomfort. And I tell owners, if in doubt, they can take the cast off themselves. If they do so, there's a high risk that the tendon repair will fail, but better that than we have a catastrophic soft tissue complication. So I would normally say, if they're at all worried, then to call us, and we always have somebody available to speak to by phone. we would see the animal back very rapidly if they were concerned. But in a critical situation, then I would say they can take the bandage off themselves. At 6 weeks, I get them back and I take the bivalve cast and dressing off. And I used at this stage to put just a soft padded dressing on for 2 or 3 weeks. I don't do that anymore. So this is that same dog when the cast has come off. Now you can see there's a pimple on the left hind limb. Still got bilateral disease, so it's got a functionally very short right pelvic limb. This dog had some minor rubbing over the head of the fifth metatarsal, which is one of those sites that we see issues, but it was minor. It healed within a few days, so I wouldn't see that as a major issue. And I guess it wouldn't be that unusual to have some areas of erythema that I might find when I do the bandage changes. Now, in terms of the bandage changes, I do these initially every 3 days, and then I stretch out to weekly towards the end of the 6-week period. So there's a reduction in the frequency of dressing changes. I share Mark's view that you have to do these right. And I think it's very hard to expect anybody else to care as much as you will do about how these go on. And the potential for soft tissue complications is so great that I'm maybe a little bit precious about this, and I will redo all of these bandage changes myself. So I guess in the outset, when I'm talking to owners, I ensure that they understand that this is a big deal and that they are prepared to drive back and see me. I don't delegate this out to the referring practices. And I will arrange the bandage changes for times when I'm available to do them. And I will tend to do them myself. I don't sedate dogs, or at least as yet, I've never had to sedate a dog or a cat to do these. So I do them in lateral recumbency with restraint. If I just go back to here, the key for me is having somebody supporting the forelimb and the dog or the cat's head and neck, and then somebody else holding the hip in a kind of a standing angle, so mild extension. And without that, I've found that the animal will tend to flex the limb up, and it's almost impossible to get the material on in the shape that I want it. So just holding the stifle, just that hand on the cranial aspect of the distal femur helps hold the limb position, allows me to put the cast on. And as I say, as yet, I've been able to do these without any kind of sedation. If I see any areas of rubbing, then I may modify the bandage material or even the cast. And I have in the past come back and removed more of the cutout at the caudal aspect of the proximal tibia over the gastrocs. And I guess I've increased the amount that I remove at the outset as time has gone by, because I perceive that can be a site where we see issues. So I take the bandage off after 6 weeks. I carry on with a regime of 5-minute walks several times a day. And then after that, I have a gradual, I'll see the animal again at 12 weeks after surgery. And from there, I have a gradual increase to normal activity. I tell owners that when it comes off, the hock will tend to have a restricted range of motion, which increases over time. And then there's a dog bilateral surgery, and is about 5 months after the second surgery. So I'd expect them to go back. This black Labrador that's had the surgery rather than the bearded collie. I'd expect them to go back to pretty normal function. And I'm disappointed if I see elongation in the mechanism. So I would generally expect pretty normal function in these dogs after a successful surgery. So that's the way I do it, which is somewhat different to Mark's. I quite like the simplicity of Mark's. We were talking earlier about why we choose the way in which we do it. And it's one of those things where I think we're both influenced by the people who trained us. And Mark was trained by somebody who was happy using casts, and I was trained by somebody who was very keen to avoid them, and hence my tendency to go for a bivalve. Good, let me stop sharing my screen.
Excellent, thanks, Jonathan. Let me share mine again. Great. Really good. Your little zigzag, Jonathan, the only thing I would say is that it looked worryingly like an ECG trace for an orthopedic surgeon.
Well, yeah, but it makes the medics think that we're cleverer than we are.
Yeah, absolutely. So, I mean, I think hopefully what you can see from there is that maybe Jonathan more so than me, but we both really sort of take care what we do there. This isn't just slapping a cast on. This is, you need to be careful. And if you are, you can avoid problems. Other options for immobilization, well, there was the sort of full cast that I showed you. There's the bivalve that Jonathan showed you. No problems with using a splintered dressing for the whole 6 weeks if you need to. So an example of that would be, for me, cases that present with maybe they've already been immobilized before you see them. They've got some wounds somewhere, or they've been very plantigrade for a long period of time and they got a little rub somewhere. Something like that, where you're not happy to put a cast on. I mean, you could use the bivalve, obviously, because you can check it, but there's the option there. And if you have a rub with a cast and you have to take the cast off, you can easily drop back to a splinter dressing that you can change regularly. That's fine. We talked about orthotics a little bit earlier on. So if you were going to use an orthotic, you really need to use a grade 3 or 4, where you've got something rigid in there to keep it immobilized in extension. I talked about my sort of issues with that. I do quite like orthotics for lots of things, but for this, where you don't want the owner to be taking it on and off every night, it worries me a little bit. And I can think of one case where I've had to use a transarticular external fixator because of some severe soft tissue injuries. So that's a possibility as well. But I'm sure we all know that is a lot of hassle, and if you can avoid that, I would do so at all costs. Very briefly, this is sort of not really for you're not able to use this as an immobilization technique when you're using vet-leg implants, because of course you've drilled them down through the calcaneus. But for a primary repair, you can also use a calcaneal tibial screw. We won't go through this in detail, but it works pretty well. I would put them in as positional screws, and I would put the screw in overly long. I would also put a cast on top of these to protect the screw, sort of belt and braces, if you will, or certainly a splinter dressing. I know colleagues who don't do that, but it does maintain extension pretty well. Really, this X-ray is in here just to show you how extended you can get the hock. And that really does unload the common calcaneal tendon mechanism for me. So the key points really for me with immobilization is it's got to be in full extension to unload that tendon. Whatever you're using, Jonathan and I have both said you need to check these regularly. Owners need to check them on a daily basis, and either the referring vet or yourself needs to check it at least on a weekly basis. For me, it needs to be on there, and the same for Jonathan, for a minimum of 6 weeks. When you take these off, it's not uncommon for the dogs not to immediately want to fully weight bear, so they can take a day or so just to get used to putting that foot down. I don't know if that's your experience as well, Jonathan, but that doesn't worry me if you take it off and they're a bit tentative because they've been in extension for 6 weeks. So don't worry if that happens. So that's really it with regard to immobilization and the sort of post-operative care. I think we'll use the rest of the time just to sort of skip over some of the other complications that you might see, and I think Jonathan's got a few as well. Obviously, neither of us have ever had a complication with this. Don't recognise any of these problems. Major ones for me, yeah. Infection. It's always a concern with any sort of braided material, and when you're treating these chronic cases and you're excising all that scar tissue, it really is or can be catastrophic, because if you need to remove the implant in the immediate post-operative period, your options are limited, well, surgically to an arthrodesis or an amputation, or managing it long term with some sort of orthotic, which might be for a significant period of the dog's life. Failure of the repair, so either the sutures pulling out proximally, the myotendinous junction failing, or the implant pulling out from around the interference screw. I've only seen the implant pull out from around the interference screw in the very, very first stages when we started sort of looking at this way back and doing testing. And that was a completely different type of interference screw. I haven't seen it pull out around the interference screws that we currently use. So for me, if there's a failure, it's very likely to be proximal. I have seen one case where the screw loosened, and I'll show you that in a second. That actually wasn't a problem for the dog, and I'll show you again. Cast sores, you can see those. They can be mild, they can be severe, but we've taught you about how to manage those. This last one here, loosely defined as a complication for me, because although, as Jonathan said to you, you don't really want to see these drop down at all, I recognize that they do. So I would put these, again, we're not here for surgical technique tonight, but for me, the tension is the tricky bit of this whole surgery, how tight you put it in. And if I was going to put them in slightly too tight or slightly too loose, I'd go slightly too tight every single time. Because when you've had a chronic issue with the gastroc, the muscle belly tends to contract up a little bit for me. And when they start loading again, that can relax down. And it can, if it wasn't tight enough to start with, mean that it's the hock angle is slightly lower, or the dog's slightly more plantigrade than the other side. Now, what we're not talking about here is a sort of complete failure where they drop down a long way. They often, with chronic gastroc issues, in my experience, don't drop all the way down to the floor like they would with a laceration. And that's because the SDF, where it sort of encases the back of the calcaneus there, acts a bit like a bit of a sling support. So the SDF's often, or almost always, not involved in these chronic cases. So it acts and just stops them dropping right down. But if you do get a little bit of relaxation, the dogs can still do very, very well, in my experience, because unlike when you have a rupture or a detachment from the calcaneus, they have a sudden end point. So although it might be a little bit lower down, they still have a point where it won't go any further. So if it's slightly lower, you're probably going to be fine, and I wouldn't rush into a revision, but keep an eye on it.
So Mark, if I can I butt in a second?
Yes, absolutely.
So I deliberately put these in really quite tight because of that concern of the relaxation of the muscles. So I do these dog in sternal recumbency, hips extended, hock is fully extended, but I'll flex the stifle by 15, maybe even 20 degrees, so that I can achieve an excessive tightness. So I find at the end of surgery, I can't flex a hock as much as I would expect to with an extended stifle, but that seems to work with these chronic cases. It seems to end up 6 weeks later with an appropriate length. Do you do something similar? Are you less aggressive in terms of the tightness that you put in?
No, I would be exactly the same. And you know, on a, you know, I'm going to drift in. We're just going to talk about some little surgical things here. This is fine. So I would be exactly the same. I would put them in overly tight. And if I don't think I've put it in tight enough when I go to check at the end of surgery, I would never, ever, ever take the screw out, because I think once you put the screw in next to the implant, it's chewed it up a bit. That's part of how an interference screw works. What I would do is take the sutures out and tighten it proximally, and I would flex the stifle more to give me some more tension and resuture it. So if I had to do that, that's how I would do it, and I would go overly tight. There is one case I think that I put in too tight, and the dog did all right, but it was slightly more extended than I wanted it to be. But yeah, I was going to say I don't think you can put them in too tight, but I've done it once.
Yeah.
So with regard to complications, there's only one study published, and this was the sort of the first 10 cases we did really back in the day, and I don't think these figures would really reflect my experience now. the technique has developed and the implants have developed a lot. The two major complications were both infection. There were 5 minor complications associated with all associated with the coaptation. When you see an infection, I think there's 2 types that I recognise. Both those in that first paper were an acute sort of surgical site infection. As I say, we do lots of things. I don't get the implant out right till the last minute. I use an iodine type drape. The ones that Vetlig sell, I've actually been really impressed with, not just because we're on a Vetlig talk. Genuinely, they're really nice to use. So if you haven't spoken to Karen about those, do so, because we use those now. But that stops the implant touching the skin and reduces the chances of contamination. So all the things you do with any sort of braided material. But if you have an acute infection, you know, it really worries me then that you're going to have to take it out. I would treat them with antibiotics for a prolonged period of time, and I have had 1 or 2 settle down with that. But explantation is certainly a possibility, and we talked about that earlier on. There's one case where it had a chronic infection, and I know a couple of others have been reported or certainly one more that somebody's contacted me about, where the dog, months down the line, 8-9 months, ended up with a discharging sinus, sort of proximally where the implant was. The dog was never particularly lame with that. It never went plantigrade. And my colleague, whose case that was, removed the implant, which I think was a horrendous surgery from a point of view trying to dissect it out. But it cleared the infection with the course of antibiotics, and the dog was never plantigrade afterwards or before. So that dog actually did fine with an explantation long term. Again, I recognise that I've seen a case, and I'll show you some slides of it, where it ended up with an infection secondary to having soft tissue wounds from its coaptation. So rather than being an acute surgical site infection, this dog for me definitely had an issue where it ended up with a wound at the point of its calcaneus from its immobilization, and the infection started superficially in that wound and then tracked in from there. We've just sort of talked about failure of the repair and the tension and things. They're normally fine. And it's normally for me in that second 6-week period where you start to notice it or get that report. As I said, I wouldn't rush in if there's a little bit of relaxation, because you certainly get that. I would wait and see. But again, if it fails completely, you may be looking at a revision, and whether that's explantation, arthrodesis, and orthotic, or revise the surgery and trying to tighten it. That's certainly possible. Just to sort of show you this is not the implant that we use now, but this was one that pulled out, and it just shows you. I think this was about 3 months down the line, but you can see that you've got some integration, you've got some tissue forming around the implant there. But it had pulled out from around the interference screw again, the old type of screw used. I've not seen that with the Novetech screws. This was a really interesting case because this was a Doberman, and it did absolutely great. And about 7 months after the surgery, the owners contacted us to say it was a little bit lame, and it was uncomfortable when you palpated over the proximal calcaneus. Now this is when with the sort of original technique with the tunnel, the blind tunnel sort of down the length of the calcaneus, and the screw had started to back out. Now the dog was probably 1/5 lame. It was uncomfortable when you squeezed at the insertion of the gastroc, but it was never plantigrade. And a colleague of mine removed that screw through a little stab incision. Dog did absolutely fine afterwards. 18 months later, the dog had CT scan due to a problem in the contralateral limb, and the vet, just for interest, sent me these images from where we'd removed the screw. The dog was doing absolutely fine at this point, but you can see where the tunnel was. You can see it starting to infill with bone a little bit. Just an interesting case, really, but it shows you that we do get some integration here, because it's not the screw holding this in at this point. Last sort of case from me, and then I know Jonathan's got a couple to share with you as well, but this is the sort of full house of potential problems that you can see. This is a dog that had a primary laceration that was neglected for about a month, and I augmented a repair with the Novaten 8000 ligament. Dog did fine up to about 10 weeks, and then it started to get progressively more plantigrade. It just got worse from there, really. The owners reported that the dog was actually much happier than it had been before the surgery, and it was brighter and it wanted to use the leg where it was non-weight bearing before, but this just got progressively worse from there. So we were talking about what we were going to do and how we would manage that, a revision and arthrodesis, and it was managed with a splint, and the owners were a reasonable distance away, and it was having regular dressing changes elsewhere, and then it decided to chew its splint, and that caused some problems. So this dog ended up with significant soft tissue injuries that then got infected, which became a problem. It ended up with some swelling right up the back of its gastroc. It was managed with about 6 weeks of antibiotics. But this dog actually has a lot of other issues, and the owners were unsure whether to manage it with another sort of intensive surgical procedure, either a revision, which I wasn't very keen on doing, or ultimately an arthrodesis. Amputation wasn't an option for this dog because of other issues. So I talked to them about an orthotic, and referred this case to a former colleague of mine, Diane Messam. Those of you who don't know Di, she's the head of physio and rehab at Davies Vet Specialists, and is probably one of the best people for orthotics in the UK. She certainly does a lot and runs courses on it, but if I've got a troublesome case, I'll get her opinion for sure. So she had an orthotic made for this, and fitted it so we could manage the wounds. And this dog's now very happy with its orthotic. The wounds have all healed. The owners have decided that they're not going to put it through any more surgery because of some comorbidities, but it's coping very well, and is doing a couple of miles a day with the orthotic on. So yeah, progressive failure, soft tissue injuries, infection. I think that's the full house in one case. So Jonathan, do you want to share? If I stop, you can.
So Mark, when you take your cast off, how often will you see some signs of soft tissue morbidity?
I wouldn't say. I don't have a percentage to you, but rarely something very significant. So an occasional little rub here or there, but yeah, nothing that worries me or needs any further treatment for the vast majority of cases.
Mm-hmm.
I would say if it's had a problem, I'd have known about it earlier on because of that education we talked about with owners. So I really don't see things underneath the cast that I wasn't expecting. I would say if I see a problem, it's proximal or distal, and I've known about it sort of earlier on, if that makes sense.
Yeah, very good. So I think this case here was maybe the second or the third one I did with the old system with the single tunnel, and it's not a great bit of work. As you can see, the tunnel isn't quite where it should have been. So really very plantar and also too medial. And so I put the prosthesis in, tightened the screw, and had that slightly disappointing crack as the calcaneus split. And this is one of those where I really didn't know if it was going to hold. So I put a couple of 2mm lag screws in. Actually, before I putting some context in here, when I started doing these, I didn't realize about tapping the tunnel with a screw. And so I had some real challenges where I put the prosthesis in and then try and introduce a screw and have enormous difficulty getting the screw to engage. And subsequently, when I realized that you could just insert the screw, it would create a tap, and then you take the screw out, then you put the prosthesis in and reinsert it. It's enormously easier. Anyway, I didn't do this here. I didn't tap it, so I placed the prosthesis, I put the screw in, applied some pressure to get it to engage, and the calcaneer split. So I put a couple of lateral medial lag screws in and sent the dog on its way with the normal regime of a bivalve cast for 6 weeks, 6 weeks of rest, and I got away with it. So my impression is that, so it's right pelvic limb, so the dog did well. It didn't obviously lengthen or relax. I think other people have managed this in the same way with similar outcomes. So if you have a fissure, then I think it's worth persevering, trying to reinforce it with or protect it with lag screws, with a reasonable chance of a successful outcome. So that was an intraoperative complication, but no significant effect on how the dog did. This is my case where I just rolled every issue into one dog, and this is my one true complete and utter failure with this system. So this is a dog. I'd seen one of our residents. They passed it on to me for the vet leg, and I kind of started off badly and then it went worse. So it was a slightly curious case. This dog had an insertional tendinopathy and then evidence of swelling in the mid-tendon, and then swelling at the muscular tendons junction. Now, when I put these in, I like to bring the prosthesis right up into the between the bellows of the gastrocs. So I tend to use a Nova Lig rather than a Novaten for medium and larger sized dogs. And for one reason or another, we didn't have a Nova Lig in, so I used a Novaten, and it came up a couple of centimeters proximal to the muscular tendinous lesion. Anyway, I put the prosthesis in. I was happy with its tension. Put the bivalve cast on. And my second mistake was that I utterly failed to properly communicate with the owner about looking after the cast and about looking out for issues. And she cheerfully came back. This is probably about 2.5, 3 weeks after the surgery, and said, yeah, the dog had some issues over the previous 4 or 5 days, but she was relaxed and smiley. I took it off, and I had this wound on the caudal aspect of the stifle, so it's gone through the skin, subcutaneous tissue into the muscle. The remarkable thing is that this dog never ended up with an implant-associated infection, so this wasn't that far away from the prosthesis. Anyway, I managed the wound healed by second intention, and after the 6 weeks, maybe slightly longer, I took the cast off, sent the dog away, and a couple of weeks came back later. It came back and it was plantigrade again. So this dog, we had no failure at the insertion site down at the calcaneus. It was a proper failure of the sutures and a failure of integration proximally. So this dog ended up with a pantarsal arthrodesis, and I have this as my get out of jail card. I agree with Mark. You can do a PTA as the outset, but I think we can do better, and I think most dogs do well with augmented repair. But yeah, I think my failures with this case, I didn't properly appreciate that there are multiple levels of disease. I didn't have as long a prosthesis as I would have liked, and I failed to properly communicate the bandage care with the owner. I think even if I had communicated better, I suspect this dog would still have failed. I think there's either a fundamental problem with the tissue or a problem with the or it's just down to the length of prosthesis I put in. Now, Mark, you were saying about what you do when you, if you're not happy with the tension, and how you'll always resuture at the level of the musculotendinous junction. I've kind of taken the opposite view. I've been more concerned about tissue mobility if I take those sutures out and resuture. And so I tend to retighten down at the bone. I completely take on board what you say about the screw chewing up the prosthesis. I guess I've tended to figure that if I'm going to retighten it, I'm going to be pulling it through at least another 5, maybe 10 millimeters. And therefore I'll have another 5 or 10 millimeters of fresh prosthesis that will engage with the screw. And so I'm not worried about that. And I have wondered about putting a second screw in through the oblique tunnel, maybe downsizing the screw slightly, but going for 2 points of fixation. I wonder if one were concerned about damage to the prosthesis by taking out the screw and replacing it, whether a second screw might be a way of mitigating against issues there, albeit that you want to be quite careful size-wise so as not to split that proximal part of the bone. What do you think?
Yeah, no, that could certainly work for sure. I just worry that I'd take the screw out and I go, well, that's actually, it's really chewed up because that's sort of how it works. And then I'd try and, I haven't got another one on the shelf and blah, blah, blah. And yeah, I suppose it's you pass a point of no return, don't you, with the surgery. When you chopped out all that scar tissue, you've got to it's not a sort of, oh, it'll be okay for a little bit. It's I've got to put something inside. Maybe the answer is I should have another one on the shelf always in case I need it. But yeah, I haven't done that, but I'm interested to know that it's fine if you do that, so that's good.
I've done it a couple of times, so maybe I've been lucky, and maybe every time from now on I'll get into trouble, but on the basis of a couple, it's been okay. And the threads on the screws always strike me as being quite gentle, that they have quite a nice radius of curvature on the very edge. So yeah, maybe I'm being optimistic, but I figured it's been okay, and so far I've got away with it. Some
of the cadavers on the courses, when you take them out and try and use them again, they have really chewed them up, if that makes sense. So yeah, and but I genuinely it's good to know that you can do that, because I agree, taking your sutures out is not a great thing to have to do. The ideal thing is to get the tension right first time. So this is probably the most depressing webinar I've ever done, just putting up loads of my cases that have gone wrong. But thanks everyone for joining us. We have time for some questions, I'm sure, that we can answer.
A few on the Q&A, have they all been answered? There's one in the chat. So there's one about pantarsal arthrodesis.
There is a few questions that have been answered already by writing. Maybe it could be great just to go through them to make sure everybody can access to the answer as well.
Yeah. So Rob asked a question about how often I check my cast and change the dressing. So I do it every 3 days initially, and then by about 3 weeks, typically I've extended out from 3 days to 4 days to 5 days to 7 days. So normally at 3 weeks, it will go down to weekly, but it's a judgment I make based on how the wounds are looking. If there's evidence of morbidity, then I'll maintain a higher frequency. If I'm happy with how everything's going, then I'll speed up the reduction in, or the reduced frequency. Monica asked about using a calcaneotibial screw and then how you might avoid pressure problems with the cast, and I guess Mark's probably better placed to answer that. I'd never use a cast or splint or dressing with a calcaneal tibial screw. I did in my residency and initially afterwards. I'd always put a padded dressing on, and it's a bit like pancarpal arthrodesis. I did it because I believed that was what you had to do, and then I stopped doing it, didn't have any issues, and haven't done it since. But as Mark said, different people have different approaches. Yeah,
I would agree. I don't think it's essential, and I have a colleague who never puts them on, and I can't say to you that I think it's essential at all. It's a sort of force of habit, I suppose. I think for a Labrador sized dog, you can easily get a 4 or 5 screw in there. There's some tips and tricks to placing those, which we cover on the course. Perhaps we can do some of that online at some point. But I think if you place them well and you use a big enough screw, they're very unlikely to fail, for sure. And the question about how long to leave it, just long enough that if it did fail, you can get round the front and take it out. So I'd 4 mil instead of 2 mil, something like that. I've never seen one cause a problem being cranial.
Yeah.
You've got some from James Pratt here that haven't been answered, which is, what do you estimate your current rate of infection to be? And have you ever used the Vetlig implant to treat avulsion of the origin of the lateral head of the gastroc? Oh, no. Oh, so I know where that's come from.
Shall I give my...
Well, I know you probably know about the second.
Yeah. So current rate of infection, touch wood, and by some fluke, I have yet to have an infection. Even that case where I had the horrible soft tissue wound, by the time I took the implant out a month later or 5 weeks later, I still didn't have an implant-associated infection. So it will happen to me. But so far, I've used these on Achilles, patellar tendons, primarily, and I've not had any issues. Even using a transarticular fixator on for a stifle for an Achilles tendon, which I thought was probably a high-risk strategy. In terms of the avulsion and lateral head of the gastroc, one of my colleagues who was on the call earlier, I think he may still be Steve Clark, did one of these and allowed me to scrub in with him a couple of weeks ago. And when we talked about the case last week, the dog was still doing well. So yes, that was with a 2-tunnel technique. So 1 tunnel going from the insertion of the gastroc and coming out craniomedially, wrapping around the medial aspect, and then a 2nd transverse tunnel going from medial to lateral. And I think, from what I recall, with 2 interference screws.
Yeah, and did you fix that to the so looped it round the fibella?
Kind of looped it over the fibella, so sutured into muscular, well, into the muscle, stroke muscular tendinous junction, then over the fibella, and then through the tunnel.
So I've treated one of these with I hesitate to go into what was quite a complicated story, but I think a way that you could possibly treat these would be to use a toggle. So in a big enough dog, and I have done this, it's feasible to drill through the fibella, and then a tunnel in the femur, and then either use an interference screw like you would with the Vetlig hip approach.
And what size material?
Or tie over a button. So that would be the Carinor.
Our button, sorry. Yes, they're 2,000 or a 4,000, Jonathan. So the 4,000, you could probably, that's 4,000 newtons, and the 2,000 is 2,000 newtons. So we've got those 2 sizes. We don't do the button in an 8,000.
So I'd quite like to see another case, because so I can get better images. A case that hasn't got so many comorbidities. And, yeah, but it theoretically works. Should we leave it at that?
Well, James, I know James has got a case, you see, so that's why he's asking. So I saw him at the BVOA. So James, I do have these buttons and ligaments if you want to give me a call.
In terms of other questions, John put up a question, what do we mean by pan-tarsal arthrodesis, which, as ever, is a good question. For me, it's not really pan. I plate these medially, and so I'll do the talocrural joint extensively, and then I do talocentral, centrodistal, and the medial aspect to the tarsometatarsal, but I make no attempt to get over to the calcaneocaudal or the lateral aspect of the tarsometatarsal joints. Are you the same, Mark, or do you have a?
No, yeah, it's exactly the same. Yeah, yeah. But I would say not a very frequent surgery for me to do, to be very honest.
Yeah.
Maria's question, I think probably if you I think that's more about the sort of in-depth surgical technique sort of stuff, and maybe we can do a webinar on that as well, or if you're available to come over to the UK, there's an excellent course, I believe, in February. Is there any places left on that, Karen?
No, but I'm doing a waiting list because everybody who says they wanted to come hasn't necessarily paid, so it depends. But we are pretty much rammed, yeah. So I think we have to do another one. Yeah,
and certainly we can look at that, and it's a good day actually, because there's plenty of practical opportunities there. So maybe do that, and and we can possibly think about some online provision as well. We did a few online courses during COVID, which actually worked remarkably well. I was surprised at how well they went. So it just enabled people from. We did it sort of over webcam, and we sent some kit out. So we can maybe look at that as well.
So yeah, I think that's probably a good idea. Maybe actually doing some more webinars, because then people can sit at home and not have to kind of try and get a train somewhere. Okay, so have we answered all the questions? I think so.
I think so, yes. Yeah.
I think so. Well, thank you very much. Thank you so much, Mark. Thank you so much, Jonathan. Thank you very much, Victor, for doing all the technical stuff, which I certainly couldn't do. And I appreciate everybody's time sharing your experiences. And I really hope that this has been extremely useful for the vets who've been watching. It's been really, really helpful for me. And I guess for Victor, it's useful for you guys too, over there in France. So thank you very much. If anybody needs to get hold of me, if you can go on the Vet League website, or it's karen@vetleague.com. And have a very happy Christmas, everybody. And yes, thank you for attending the webinar.
Thank you, everyone.
Thank you, everybody.
Thank you, Jonathan. Thank you, Mark.
Thanks.
Right, well, I'm going to